It's now my pleasure to introduce to you my friend and colleague and the next president of the Society of Critical Care Medicine, Vinay Nadkarni. Vinay is a professor and endowed chair at the Children's Hospital of Philadelphia, Departments of Anesthesiology, Critical Care, and Pediatrics at the University of Pennsylvania Perelman School of Medicine. His extensive career has included not only serving on SCCM's council, but also on the board of directors of the World Federation of Pediatric Intensive and Critical Care Societies. He was the president of the Citizens CPR Foundation, founding director for the CHOP Academy for Resuscitation of Children, and the founding director for the CHOP Center for Simulation, Advanced Education, and Innovation. He has served as chair of the American Heart Association's Emergency Cardiovascular Care Committee, executive committee of the International Liaison Committee on Resuscitation, and was the founding member of the American Heart Association's National Registry of CPR in over 400 nationwide hospitals. Vinay's impressive work in pediatrics extends to his participation in the AHRQ-funded National Emergency Airway Registry for Children conducted across 50 hospitals in the United States, and the 106-site Inspire Network, and the 60-member Petty Rescue Learning Co-Laboratory that is collecting data to inform practice and help pioneer the next generation of resuscitation care. He is also the leader of the Global Resuscitation Alliance for Resuscitation of Children. For more than 30 years, Vinay has demonstrated his commitment to pay it forward, volunteering with Operation Smile International to provide craniofacial surgical repair for more than 4,000 children in resource-limited settings. Over the past 5 years, he's mentored the growth and development of the Pediatric Simulation Training and Research Society across India, and the birth of the ABC Stop the Bleed program, taught to rickshaw drivers, shop owners, police, first responders, and high school children in India. Please join me in welcoming our 52nd president, Dr. Vinay Nadkarni.
Thank you. Well, thank you, Sandy. Good morning, San Francisco, and good morning, SCCM. It is really great to be here. And congratulations to John and to Pat, all the ICU heroes, and all of you that are heroes in your colleagues' eyes, your patients, the families that you care for. I'm really thrilled, humbled, and sincerely bursting with excitement, and as we embark on this next year and to serve you as your president. I really am grateful for the mentorship and the sponsorship and the support that my mentors and role models have provided to me, so many of you, over so many years. Also, the presidents and the leadership of the SCCM, especially Sandy, and the staff, David and Lynn, and all of the people who have supported me along the way, including my dear colleagues at the Children's Hospital of Philadelphia, the University of Pennsylvania, and of course, most importantly, my family, my wife, Ellen, who's my guiding light. Today, I want to think with you a little bit about dreaming impossible dreams. A simple message: make those dreams reality and pay it forward. Those three things, when I think about the mission of the SCCM over time, over the past 50 years, I'm struck by the simplicity of the message: dream impossible dreams, make them reality.
I'm always here for you.
Thank you. An example of the support that you get at SCCM. Sandy, I'm going to give this back to you. Thanks. And pay it forward. My parents were dreamers. My father grew up in rural India, one of 11 children, only 3 of which survived beyond the age of 1 year. A reminder of the fragility and the challenges for emergency and critical care in resource-limited settings. My mother, on the other hand, was the offspring of Russian Jewish ancestry and grew up in the slums of Brooklyn, New York after the Depression, working and living in a family bakery and experiencing life in the slums. As children, we grew up in the shadow of the National Institutes of Health, a multicultural, mixed-race family, and we really reveled in the stories of our parents' anecdotes, the struggles, the triumphs, the constant desire to pay it forward, and the priority on education, discipline, diversity, inclusivity, celebrating diversity of mind and spirit. Really similar themes that we're revisiting and reinforcing at SCCM today. Now, our founders and the first presidents of SCCM, Max Harry Weil, William Shoemaker, and Peter Saffer, they were dreamers also. They were also realists and certainly paid it forward. They seemed to peer into a crystal ball and created a vision that we are now following: personalized, goal-directed care and caring without walls or boundaries. From a personal standpoint, I remember very vividly meeting Max Harry Weil and Peter Saffer. I was fresh out of fellowship, I was green, and I was in a forum like this presenting at the CPR Guidelines conference in 1990 the evidence or lack of evidence of epinephrine during CPR. Peter Saffer on the left, Max Harry Weil on the right, disagreeing, and there I was presenting the evidence and sort of being bombarded from either side and literally torn apart. I was dejected. I retired to the pool and was sort of licking my wounds after the presentation, and each of them individually, passionately and compassionately coming up, sort of supporting me, giving me the information, sharing, inviting me into the family of critical care medicine, and continuing to sort of stimulate and motivate me to move forward, paying it forward. Now we are faced with what people call unprecedented challenges. We're emerging from the COVID pandemic. But in every generation since SCCM was founded, we have faced unprecedented challenges. If I reflect back on my own experience emerging from fellowship to my first job in private practice in Delaware in 1990, there was no internet. There was no MRI, limited availability of CT scans, no electronic health records, primitive cell phones. We rationed pulse oximetry. End-tidal CO2 only existed in the operating room. We had limited or no access to ultrasound. It took us a day or two oftentimes to get an echocardiogram. There was no Facebook, there was no TikTok, there was no social media. We've come a long way. But we did experience unprecedented challenges. I remember that the HIV and the emergence of AIDS and the feelings of helplessness in treating that, and then the discovery of the breakthrough medications that changed the paradigm for that. The trials of magic bullets like anti-endotoxin antibodies, anti-TNF antibodies, trying to find that magic bullet, being encouraged and then failing. And the roller coaster of steroids and glycemic control, the shock of war and conflict, the disruption of transition to Y2K, and then 9/11. And then Ebola, now COVID. Unprecedented challenges throughout the history of critical care medicine. But with that the theme, we have discovered that all of these critical care conditions are really time dependent. We've consistently learned that time is heart, time is lung, time is brain. We often have very simple evidence-based interventions that can minimize, prevent, or reverse critical illness. An example of this, a couple of weeks ago, was seen by millions on TV when Damar Hamlin collapsed and died on the football field. However, simple interventions, CPR, an automated external defibrillator, a trained emergency response, and excellent critical care reversed that process for a good outcome. That is progress, a system of care that works. We have also learned of the time dependence of disturbance and recovery from our patients and colleagues. Indeed, some of you may remember that 6 years ago, my sister Nalini was on a stage like this in Hawaii and spoke of her personal experiences between earth and sky, disturbance and recovery, traumatic injury and rehabilitation, and the toll that it can take on one individual, a family, a community, caregivers, and providers. I want to reflect for a moment on my journey in critical care and a few personal thoughts about my aha moments that I hope will engage and resonate with you. I remember, excuse me, I remember my first night on call as an intern, caring for a child with a mediastinal mass who had been sedated. Thank you. And here we go. Thanks. This child who had been sedated, a big mediastinal mass, occluded their vena cava, blood returned to the heart. I remember climbing on the stretcher as they were rolled into the operating room, doing CPR, a lifeless child, and then having a first-hand view as the surgeon cracked the chest, lifted up the mediastinal mass, unstrangled the vena cava, blood refilled the heart, and the heart started to breathe spontaneously. A vivid memory of reanimation and possibility. I also remember countless hours at the Naval Medical Research Institute in the animal laboratory studying animals with septic shock with people like Joe Carcillo, Pat Kohanic, Rich Mink, and others. Hours and hours putting in PA catheters, manually calculating and measuring cardiac output and vascular resistances, working together to remove evil humors with primitive forms of CAVH and charcoal hemoperfusion and anti-endotoxin antibodies, and sitting for hours and hours and monitoring the owls and just discussing the challenges and the paradigms that were going on in critical care. Those were cherished moments. I also remember the exhaustion and the saga of HIV and AIDS and the emergence and scourge of things like pneumocystis, the dramatic effects of early trials of surfactant and liquid ventilation for premature infants, the frustration of trying to treat RSV infection with immune globulins and inhaled ribavirin, and early efforts at ECMO, both triumphs and disasters. And I also remember, as many of you will, the desperation and gut-wrenching feeling of helplessness as we exhausted the limits of medical science and of human endurance, and watching and being present when some of our patients drew their last breaths and succumbed to disease. Indeed, each of us have our own aha moments that weave a tapestry of emotion and motivate us to persist and to pay it forward. We can see that since the inception of SCCM to now and the future, we have made tremendous progress over the past 50 years, and transformative breakthroughs that have been both leaps and also incremental improvements. Progress has been marked by this combination of trial and error, systematic study, and serendipity, with progress towards a true learning healthcare system. With you, your participation, your expertise, your guidance, the SCCM has supported this journey in patient care, quality improvement, research that is rapidly translating new discovery to education, to implementation, to outcome. We have dreamed of, made reality, and are paying it forward with new programs and new wings on the foundation of SCCM. The roadmap for this journey is really a combination of medical science times educational efficiency and local implementation. That is leading now not just to survival, but transforming our work products to survivorship. The SCCM has now invested time, effort, and dollars to hire evidence evaluation experts, human factors scientists, implementation scientists to support us as volunteers to accelerate and smooth this process and to change it from a multiplier effect to an exponential, to be exponentially faster, sort of at warp speed. An example of SCCM building this infrastructure to catalyze the formula and push it forward is the Discovery Research Network. In just over 5 years, Discovery has fielded more than 100 investigator-initiated research proposals, built 8 discovery programs, and obtained more than $4 million in extramural funding. Examples like SARI PrEP, the virus registry, the FDA Cure ID programs. SCCM Discovery has enrolled more than 100,000 subjects in research, dispersed more than 500,000 in young investigator grants, and invested more than $3 million of SCCM money in the Discovery Data Science campaign. Critical care and data science now has a significant home at SCCM, and we're proud of it. But the path forward is not all numbers and data, it's people. Humans solve problems. SCCM is paying it forward. We heard about the FCCS family of courses that's being disseminated across the globe, including to conflict and war-torn areas. We heard about the AIRS project promoting critical caring everywhere, and so much more. We have to dare to dream, to make dreams reality, and to pay it forward. As a final thought to leave you with this morning, I thought I would make a pledge to you and to the society. And although I'm not Hawaiian, I do wear Hawaiian shirts. And I resonate with the philosophy and the harmony of the Hawaiian setting. And in Hawaii, there's a little custom that each time you visit, you make a pledge to the land. One such pledge in Maui is entitled Malama, or caring, and I thought it was appropriate to adapt it because we are the society of critical care and caring. It goes a little bit like this. I pledge to Hana Kupono to do what is right while visiting this landscape. I will mindfully experience the beauty of Aina, the ancestral landscape, and the welcoming spirit of Kama Aina, the local people. I will be ha'aha'a, humble, and kupono, appropriate in my actions. I will remember that each step I take is upon someone's land, someone's home, living history, something sacred to them. It is my kuleana, my responsibility, to seek knowledge and ask before asking. I admire this landscape and will take nothing from this wahi, this place, but memories, and leave nothing but gratitude. I pledge to Malama to care for this landscape, the people, and our society. Mahalo. Thank you very much.